Yes, this study was initiated probably in 2017 or 2018. At that time, we were starting to use PSMA PET, and with a dramatic change in terms of disease patterns we could see and impact on management. And at one of our regular research meetings with my colleagues, radiation oncologists, Dr. Nickols and Dr. Kishan, we were wondering like how much PSMA PET can impact the radiation therapy planning, because it seemed that many lesions were seen outside of the radiation therapy fields. And so the trial is about looking at patients who do a scan, a PSMA PET scan, versus the patient who don't do the PSMA PET scan. And they both are treated with salvage radiation therapy, and we'll see if the difference that we see potentially on a PSMA PET scan actually translated to difference in terms of treatment results and treatment outcomes. So this idea was suggested by Dr. Nickols. We did a preliminary study. And then also in the past, let's say 5 years, at each meeting, at each roundtable, at each conference experts, the question on how to use at best PSMA PET and can PSMA PET really improve patient outcomes comes back all the time. So we hope that this trial will be able to give a little bit of information regarding that.
Yeah, those are good questions. So this was, as Dr. Calais mentioned, a secondary analysis. This wasn't the primary endpoint of the study, which is looking at more long-term outcomes, but rather, the secondary impact, a secondary endpoint analysis. And we did find a significant increase in changes in treatment management, specifically treatment escalation. And I think a very unique and important feature of this study is that we have that control arm that allows us to make comparisons. So, of course, probably having a PSMA PET, logically would change management. But there are other things that change management, like getting an MRI for radiation planning, getting a fluciclovine PET, getting a deciphered genomic test, all of these things, the patient preferences. So when you see a patient and you decide to do radiation, you don't necessarily have the final plan in mind. So there's actually a floor to management changes that I think has largely been undefined. But in this study, a very unique aspect of it is that everyone that enrolled on the study needed to basically discuss what their radiation plan would be and actually put it on paper before the patient was randomized. And that allowed us to look at changes in management in both arms, and I think gives us a very clean comparison. You are correct. There were major management changes in 33% of patients. And I think that is along the lines of what we expected. And part of the utility of this scan is that it would allow changes in management. But I think it's interesting to have seen the number of changes even in patients who didn't have a PSMA PET on the control arm of the study.
I'll echo what has been said so far. I think this is a very innovative trial. I think, looking at management changes, you'd think that if PSMA PET is going to impact long-term outcomes, it's got to do that some way, and that way is through change in management, change in what you would have initially planned to do. And thinking, big picture, how could a PSMA PET change what you're going to do? Well, it could reveal cancer in places that you didn't expect. That could have a dramatic change in management. Maybe the patient actually has metastatic disease that changes things quite a lot. It could be that you see a pattern of disease in the lymph node regions that you wouldn't have thought of or wouldn't have anticipated, and that's going to change how you're going to draw your volumes in the areas to be irradiated. You can change the dose that you're going to give. If you can see the cancer, then you can give it a higher dose and have a better chance of control. And we saw all of this actually in the trial. Everything that you could expect, we did see, including evidence of metastatic disease that was otherwise occult. Changes to treatment volumes, dose selection, incorporation of systemic therapy that might not otherwise have been included.
From my standpoint, it's a valid concern. So technically, people would be concerned about possibly over treatment, under treatment, upstaging, the Will Rogers effect, stage migration, all that. And those are all reasonable concerns to have. But at the same time, in this specific context, for years, the problem in salvage radiotherapy has been, we know there's a recurrence, the PSA is rising, but we don't know where it's coming from. So in that sense, having, you know, the enhanced sensitivity of a novel imaging test is critical, because it may actually improve our ability to treat these patients. I think probably the most dangerous thing would be, you know, under treatment. So we wouldn't want to necessarily deprive standard of care treatment for somebody because of something seen on a novel imaging test. But, you know, that's why trials like this are critical. You know, we had a narrow window to do a study like this. Congratulations to, you know, Dr. Nickols and Dr. Calais for pulling this off. As we can see, you know, PSMA was approved shortly thereafter. There is no longer really an opportunity to do studies like this to define the use of this agent and imaging modality.
If we take a step back just for a moment and think about imaging of systemic disease and prostate cancer and go back in time, not even very long, it was probably the worst imaged cancer around compared to the other modalities you had for other cancers. Now, fast forward to today, or even just, you know, a couple of years ago, and it's arguably one of the best. You know, the accuracy is so much better with molecular imaging than it was for planar bone scans, and it's hard not to use it. And you know, it's not just impact on outcome, but actually, you know, the accuracy of staging, because that has prognostic significance in and of itself.